Very good day, everybody. Today I'll be talking, basically taking a class on bladder physiology, bladder, I can say bladder pharmacology, bladder physiology, and there is a lot to this chapter. I mean, too much of, I can say, concepts. Those are very easy to understand, but very easy to forget also. So I will start sharing my screen with my slide, and I will go along. With also with my whiteboard when I go to the different pharmacology part, bladder pharmacology part. Okay, now fine. So that's the thing. For those of you who haven't subscribed to my channel, all my friends, please subscribe to my channel because we'll get a lot of these revision videos on urology. So even if you are going for NEET exams, if you are going for a DNB, MCH, exit exams, entrance exams, all this will be helpful as a uh, revision, sort of revision notes. So you can go quickly to the videos, it will be easier for you. So as we all know, urinary bladder has four parts. Basically, the base of the bladder, which contains a trigone. Trigone is basically the triangular area in between the two ureteric orifices, and also the bladder neck. Also, there is a dome, and on the superior surface, infrarectal surface, also the apex. Now, a short few things you need to know about reflux disease, as it is pertinent to urinary bladder anatomy, is that the lower in the ureter is actually coursing through the detrusor muscle. It's enclosed by a fascia of Waldia. Okay, and what really happens when the bladder is distended? Bladder is distended. What happens is this tunnel becomes longitudinal and increased in length. Okay, and so there's a lot of coaptation of the ureter passively by the, because the tunnel length is increased, the detrusor muscle compresses and the tunnel coapts. Also depends upon the pliability or the orifice opening. So there are two ways to control reflux. Either the ureteric orifice is patulous, you have to put in some dextromers like deflux materials, or you create an artificial tunnel. They create an artificial tunnel. So that's the what is known as the reimplantation. That is there's a lot of this tunneling techniques been done. Cohen's cross trigonal technique, and there is also what is known as the we'll be talking this about in a later time, polytunnel better technique. Okay, now so it's basically makes it passive occlusion, acts like a flap valve, so it prevents the reflux of the urine. And so this is, and sometimes, as you can understand, because with prolonged obstruction, there is some changes in the bladder secondary. So suppose the patient has a prostatic hyperplasia, large prostate lobes. There has been urine being contained in the bladder for quite some time. The bladder contracts. So there will formation of sacculation, there formation of diverticulum, and there's a specific diverticulum which occurs because there is weakness of the hutch of this pollius fascia, and because of the indigitating effects of the detrusor muscles at the level of the trigone. So what really happens is there is a diverticulum which outpouch is known as the Hutch diverticulum. So it can come as a short note. It can also come as MCQ questions. So this is about bladder anatomy. I'm going to go skip farther and talk about the physiology of micturition. So this is the bladder. As you can understand, bladder is supplied by the autonomic nervous system and the somatic nervous system. The autonomic nervous system will have two parts: the sympathetic nervous system and the parasympathetic outflow. We'll be talking about this. Okay, so let us come to our whiteboard. So this is very important in the sense that this is right. So this is a very conceptual. So if you get your concepts right, we are fit to go. Okay, so basically what we have is there's a two ureter, and this is the bladder. Okay, and this is the internal sphincter. In males it is known as the prostatic sphincter. Okay, or you can say internal sphincter. This is the urethra, and at the level of the membranous urethra we have the urogenital diaphragm. Transverse there's transverse peni muscles. The most important is rhabdosphincter, which is a voluntary muscle. Okay, it's a voluntary muscle. So whenever we have this urge to urinate, and because we are in a socially unacceptable position to urinate, so we can control our this by our sphincter mechanism, which is known as the external sphincter. Now, beside, I just draw three. This is the neural system. So first of all, we have the sacral spinal cord, or the S2, S3, S4, the level of the S2, S3, S4. Okay, fine. And the sacral spinal cord is the generation of, or you can say from here with a parasympathetic system and also the somatic system. S2, S3, S4. We have infralateral ganglia. We have the dorsolateral area and the infralateral area. Okay, that's so in the anterior horn we have something called the Werner's nucleus near the anterior of the Werner's nucleus, which actually produces that somatic nervous system. Okay, and outflow, somatic outflow. And then we have the parasympathetic, which is known as the parasympathetic nucleus. Okay, something over here, lateral gray horn area. This is the sacral system. Then we have the thoracolumbar system. Thoracolumbar is in T11. Basically it's T11, T12, L1, L2, L3. Okay, it's T11 to L2 basically. So this is where we have the generation of the sympathetic output. Sympathetic output is very important, and above it is the pons, where we find this we are coming to higher centers. Okay, pons, we have two centers. One is known as the pontine micturition center, and the one is known as the pontine storage center. Okay, and above it is the cerebral cortex. This is the higher center. This is the cerebral cortex. Okay, now with this in mind, let me change my color. Now, what really happens is there's something called the stretch receptors. What really happens if the bladder is about 10-20 ml, that what really happens after the person has evacuated his bladder, then the stretch on the detrusor muscle is very, very less. This is something called the stretch receptors, which carry the sensory input. The sensory input, a sensory output from the bladder into, so it's basically an admitting or afferent fibers, sensory afferent fibers from the bladder into the sacral or the neural system, which is the first station, you can say, is the sacral S2, S3, S4 segment. So this is basically mediated by the A delta fibers. A delta, they have fast and slow twitch fibers. Basically, during bladder emptiness, we have the slow twitch A delta fibers which are activated. This is a very tonic contraction, tonic level of action potential being generated, and they go to, first of all, they go to activate the parasympathetic nuclei. Okay, now this is very important to say there are two types of stress receptors, A delta and C. Or the capsaicin sensitive receptors are activated in bladder pain syndrome, mostly in the pathological states of the bladder. Okay, in the physiological states, empty bladder, it's the A delta slow twitch fibers which are activated. Now, when they go to the parasympathetic nuclei, there's generation of parasympathetic impulses. Now, that's very important. A few things to talk about. The sensation will come over here, and it will ascend. Ascend means it will first of all, it will give a parasympathetic outflow. Okay, it comes over here, right? I will talk about this later. Then it goes to the sympathetic system, which is the T11L2. We have talked about it, T11L2, now the thoracolumbar outflow, and there we have a sympathetic outflow. Sympathetic, first of all, this is the pre-ganglionic, this is the post-axonal. So there's a synapse, then the postsynaptic neurons goes to the ganglion, which is known as the inferior mesenteric ganglion, and the postganglionic fibers. These are sympathetic supply. These are basically hypogastric nerves, and they go to the bladder. Now, as you can understand, let's talk about sympathetic supply first. Okay, sympathetic supply, these go to the bladder and they activate the beta-3 agonist, beta-3 receptors actually, and they release acetylcholine. Now, there's another group of nerves, the postganglionic nerves. They branch from these hypogastric nerves and they go to supply the internal sphincter, where it activates the alpha receptors. Again, acetylcholine, again, I'm very sorry, norepinephrine is a neurotransmitter released by the sympathetic neurons. Now, these are very important concepts. You have to go very slowly. Even I can make some mistakes. Please, I will try to iron them as I go along. Try to understand these very, very clearly. If you get the hang of this concept, 90% of bladder pharmacology is done. So beta receptors, whenever sympathetic stimuli act on beta receptors, it actually it drives off the potassium ions from the cells. But what it happens is the bladder detrusor muscle cells become relaxed. So sympathetic outflow efferents, these are efferents outside, this carry sensation from the neural cord, not from the neural system to the bladder. So these are efferents. When they activate the receptors, which are beta 3 receptors, what really happens is bladder relaxation occurs. Now there is a subset which goes to activate the alpha receptors in the internal sphincter. What really happens is now the internal sphincter gets tight, contraction, constriction of the internal sphincter, so there's a holding of the urine. You can understand now. So this relaxation of the bladder and you hold the urine. What is detrusor sphincter dyssynergia? What? I'll tell you, understand very clearly. Whenever our bladder contracts, the gates must open for the urine to go out, or else if the gate is closed, the back pressure will happen back on the ureters. We talked about reflux, and if the ureters are prone to reflux, there is reflux disease. The reflux will cause kidney damage in the long term, hydronephrosis and all these things in the long term. Now, but this is what is known as detrusor sphincter dyssynergia. The bladder relaxes, the sphincter is also closed. Okay, fine. Now, what really happens with parasympathetic? Now, when the bladder is not full, the parasympathetic is not activated. It is a low tone, it's not activated. When the parasympathetic gets activated, what really happens is it has a receptors, one of the muscarinic receptors. The most common is the M3. So when the M3 receptors are activated by parasympathetic supply, which releases acetylcholine at the receptor level, then the bladder contracts. Now the parasympathetic system is cut off. Now, this is the ascending fiber which goes above, so it sends sympathetic signals, bladder relaxation, and this constriction of the internal sphincter occurs. Now it goes up, it goes to the pons, and then goes to the pons to cerebral cortex. Cerebral cortex is a social. We are social animals. We don't pee whenever we feel like to. Okay, so what will the cortex believe? Cortex feel that now the bladder is empty. Now the person he needs to store urine. He does not need to go to the toilet to relieve himself. It's very important. So it will send descending signals and activate the pontine storage center, inactivate the pontine micturition center. That's very important. Now, whenever the pontine storage center is activated, what it does, it activates, there are descending fibers as well. It activates the sympathetic outflow. So again, the same thing happens. Beta 3 relaxation, alpha 1 constriction. Now it will inactivate the parasympathetic outflow, which has been in a very low state. So there is no form of contraction by M3 receptor activity. And it will activate the Onus nucleus. That's very important. These are the pudendal nerves. These are the somatic nerves, which carry sensation to the rhabdosphincter, which is a voluntary action. It's under voluntary control. The receptor level is nicotine type of receptors, and the neurotransmitters is again acetylcholine. Now it activates the nicotine receptor. So there is also constriction of the external sphincter. Detrusor sphincter synergy. Detrusor relaxation with internal external sphincter constriction. So that I'm able to hold my urine. Next, what really happens? The bladder gets about 200 ml of urine being filled. So about goes to now 400 ml of urine being filled. Most of us individual will have the sense to urge to urinate. Now what will really happen is that, now let me change the color of my this thing, is now the what is known as the sensory input is by the A delta fast fibers. Stretched, bladder wall is stretched. It goes to the system, okay, and basically it activates the parasympathetic activity via the acetylcholine on the M3 receptors. The bladder will now contract. Now, because of fast type fibers, it bypasses the thoracolumbar area. So it doesn't have any direct. The ascending fibers have no role on the sympathetic system now. It bypasses, goes to the pons and goes to the cerebral cortex. Cerebral cortex feels he's the boss. He feels that now the person needs to go to urinate. So what it did, it shut down the pontine storage center and will activate the pontine micturition center. What will it do? It will this will send descending fibers, will inactivate the parasympathetic outflow. So bladder relaxation via the beta 3 receptors is cut off. Alpha 1 receptor inactivity, so the internal sphincter relaxes, go down, activates the parasympathetic outflow, M3 receptor contracts, the bladder contracts, the internal sphincter relaxes, also cuts off the somatic outflow via the pudendal nerve. So the external sphincter also relaxes. Now again, we have a detrusor sphincter synergia. So the detrusor muscle contracts with the relaxation of the internal sphincter and the external sphincter. The person is able to. As simple as that. Okay. So now I go back to our slides presentation. So where we were, I've just come to the different types of bladder we're talking about. So what happens in a cortical bladder? The higher center is gone. The higher center gone means the person goes in automatic state. Whenever his bladder is filled, and by reflex mechanism, he is able to. That's happening in toddlers. It's happening in dementic patients. Spinal hyperreflexic bladder, spinal shock, initial period, nerves are all basically they're all dead. Now they regenerate. Now next what happens is when they regenerate, the small capacity, because a local spinal arc happens. Small capacity bladder, hypertonic bladder, automatic bladder. So whenever there's activation of the sensory input, immediate boom, the contraction of the parasympathetic occurs of the patient void. So it's become a small bladder, unsafe bladder, and it always, because there's detrusor sphincter dysynergia, because now that whole system of sympathetic outflow being cut off, all by the higher centers are not all out. So there's a detrusor sphincter dysynergia. The bladder contracts, the sphincter may be still tight. So chance of reflux, and these are known as unsafe bladders. And then we have the areflexic bladders, where we have a below the spinal level, means basically there's no spinal reflex. Nothing happens. The bladder gets full and there's overflow incontinence, high residual and lead to infections. Sensory denervated bladders, this patient don't have any sensory input from the bladder by the endothelial fibers into this. This happens in tabes dorsalis, diabetic neuropathy, and they have overflow incontinence. They have no bladder sensation. They have to strain. So the time voiding becomes very important, and they have to go for CIS, the clean intermittent self dilatation and clearance. So motor paralytic bladders are basically the motor effect of this, the parasympathetic is gone, and it'll happen with Guillain-Barré syndrome, and they have to compress the bladder by Creed's maneuver to empty. So this is about the voluntary. It all depends. More than 400 ml, the stretching of the sensory receptors, they go to sacral, they go to higher centers. All depends. Condition is favorable, is urination, becomes unfavorable, no urination. All depends on central cortex, depending upon on the effect of PONS. So this is in very short about right. This is in very short. Let me stop the show. Very short about bladder pharmacology. I hope it's understand. So if you are a clinician and you are prescribing medicines, so if you have a person with a detrusor overactivity, you have to give a beta 3 agonist like a miravigrone, or you can give a M3 receptor antagonist like a tolterodine or solifenacine. So, and correspondingly, you have to also give an alpha blocker whenever the bladder contracts, the detrusor relaxes. So there is any form of internal sphincter, that is the prostatitis hyperplasia happens at the gate level, there's obstruction, then you have to give an alpha blocker like silodosin or tamsulosin. So we'll be talking about this later on during your prostate BPH classes. So I hope you are able to understand the different nuances of this bladder pharmacology. If you have any question, just mail me in my or you can always comment me in the comment section, and do subscribe to my channel, and also see the other videos. I've just pasted the links for the other videos so you can go through them. Okay, bye bye. The next class. Hope you do well. Bye-bye.